My name is Aya Zriki. I'm a research scientist at Johns Hopkins University. And sorry, I forgot to turn on my camera. And I do machine learning and natural language processing work in mental health in general. And I do specific work in suicide detection in social media and actually in clinical settings as well. I'm the moderator of the first session and delighted to have three speakers with us. Dr. Daniel Evatt from Defense Health Agency, Dr. Philip Resnick from University of Maryland, and Dr. Holly Wilcox from Johns Hopkins University. Our speakers will present themselves and talk about their work, perspective, and lessons related to the focus of our session, which is identifying population-level responses, risks, and strategies. At the end of the three talks, we will have our Q&A session, so please do share your questions. Dr. Evatt, the floor is all yours.
Wonderful, thank you so much. I'm waiting to see the slide presentation. Thank you very much. So my name is Dan Evatt. I'm at the Psychological Health Center of Excellence at Defense Health Agency. I lead a research team at PHCOE, and we provide research support to the Defense Health Agency and DoD, really to try to empower our policy and program makers when they have to make evidence-based decisions about emerging scientific breakthroughs and discoveries, like the ones we've been discussing today. So I'm going to talk a little bit about some of the work we've done recently to evaluate the population impact of some of the emerging approaches for identifying suicide in populations. Next slide, please. I'm a government employee, but I want to emphasize that these views are my own. They are not necessarily representative of the Psychological Health Center of Excellence, the Defense Health Agency, Department of Defense, or the United States government. Next slide, please. All right, just a quick overview of what I'm going to go over here. I'm going to start off and talk a little bit about our guideline in the DoD, which is shared with the VA for identification and management of suicide risk in the military health system. Next, I'm going to talk about some work we've done recently, and specifically a simulation we've done to better understand the analytic and practical considerations of implementing suicide predictive analytics in our system. I'm hoping that some of the lessons learned from our own evaluation could be passed on to other folks that are looking at implementing similar technologies in other systems. So I know the systems are different, but some of the underlying issues I'm going to discuss today, I think do translate to other systems. And finally, I'm going to talk just very briefly about some of the programs we have that have footprints in social media for identifying people that have, for connecting service members to care and transitioning service members between different types of care, and some of the issues we've run into with risk identification as those programs have grown in their visibility in social media. Next slide, please. So I don't think I'm telling anybody here anything new. Suicide mortality rates are increasing. That's really bad. We're very concerned about it in the DoD. In calendar year 2020, we saw a suicide mortality rate of 28.7 per 100,000 active component service members. That has been an increasing number over the last 10 years or more. So again, very concerned about that. It is a similar increase that we see in other populations and in the civilian population in general. So it's nothing specific to the DoD, but we're obviously very concerned. And so we're looking at ways that we can improve that outcome. Next slide, please. Okay, I mentioned I'd talk a little bit about how our system identifies and manages suicide. Now, I want to point out that I think someone from the VA is going to speak to this much better than I ever could. I wanted to present these slides for context, and the context here is that this is our health services. This is the way that we in our healthcare system identify and manage risk. So when we see research for new tools or approaches for managing risk, we consider them in the context of this health services paradigm. And then we apply a simulation in that context. So when I talk about the simulation later, it's within this type of context. And essentially in our system, risk can be identified in a couple ways. via an algorithm that either has a provider identifying risk or a predictive analytic approach, which is what we're going to talk about more today. And then you come up with a low, intermediate, or high risk. I think that high risk category is the most relevant to most of the approaches that have been proposed with predictive analytics. And then you have various management and care pathways based on that risk level. Next slide, please. And again, this comes directly from our clinical practice guideline. Not going to speak of that in detail. Bottom line here is we have different risk categories for high, intermediate, low risk, for acute risk level, and then that person has a care pathway based on that. But the tool that we use to do that is ultimately going to be based on the best science, right? So we can plug in tools into these pathways, but we need to use the best science when we do that. Next slide. So one of those tools that has been talked about already a lot today is predictive analytic models for suicide attempts and deaths. And they have been improving, actually very impressively from when we first started looking at these tools, 4 or 5 years ago. We've already published and done some work in analyzing these tools, but they are getting better and better. And nowadays, you'll find a lot of these tools do perform better than some of our traditional approaches, right? And they perform better than our traditional models, and they perform better than our specific analytic approaches of multiple logistic regression or clinician-based prediction. So that's good news, right? Additionally, we've already seen these models start to roll out in health systems. So the VA recently rolled out Evatt, and they had some very nice outcomes associated with that. They were able to get more people connected to care, and they were even able to demonstrate a modest improvement in suicide attempts. And it's generally true with these types of models that you see an improvement in suicide attempts rather than deaths, or there's very little improvement in deaths. And there's a very good reason for that. Next slide. And that reason is suicide mortality is a low base rate outcome. Again, I might be speaking to the choir here for anybody who's watching this, but there's a lot of problems with trying to identify low base rate outcomes, right? And this is true for research in general. It's not specific to these types of models, et cetera. So, there's all kinds of different screening methods. You're going to run into the same problem regardless of the screening method, and for the most part, regardless of the outcome or condition. There might be a few conditions in medicine where we have sort of perfect screening for low base rate outcomes, but that's the exception. So the problems that we run into are that if we see a new model, demonstrating it does better than the model we already had requires an extremely large population because it's a low base rate outcome. Additionally, even if you can sort of I hate that term, but even though you can sort of statistically demonstrate that you have an improvement, that doesn't actually translate into practical improvement in your health services paradigm. Again, I'm going to talk about that with the simulation. And finally, just the kind of general problem that's already been alluded to today, extremely low positive predictive values for these approaches. That means extremely high rates of false positives. And so you have this weird trade-off you have to make, and I'll speak directly to that in a moment. Next slide, please. So we ran a simulation based on some of the emerging research in suicide predictive models to see how these models would perform in our healthcare system. We just did this. The goal was to estimate the performance, right? So what does performance mean? That's the population impact for us, which means, how many people are identified? How many of those will be deaths? How many of those would be false positives, right? If we look at different risk threshold options for identifying people, how many would be in any of those three categories for all of those different options? And then we can use that information along with estimates of intervention effects to predict suicide death and suicide attempts prevented. Finally, we can even take it a step further and we can say, how good would an intervention have to be in order for us to see a meaningful reduction in suicides in our system? Because at the end of the day, suicide mortality is the outcome we're interested in here, right? That's where we want to move the needle. That's people's lives, and we want to see that needle move. So that's what we're looking at here. We used estimates based on the best models that we see published right now, and we also use intervention estimates. And this is an important part. Everybody doesn't do this next step. We actually look to see what happens not after we identify them, but what our estimate is for a positive impact after we treat them or provide a prevention intervention. And we use that based on emerging systematic reviews as well. Next slide, please. So this first slide, if you're not accustomed to looking at figures like this, I'll make it as simple as possible. At the end of the day, with these types of approaches, you're identifying a high risk threshold, right? I alluded to that earlier. So that means you're in the 99.9th percentile risk for suicide mortality risk, or the 99th, or the 95th, or the 90th. Higher being more risk, right? Then once you identify that threshold, in that model, people that are in high risk would then be provided additional services. Now that could depend on the model. In our system, that means we would intervene with some type of prevention intervention. Here we look to see, among the people identified in that high risk groups, how many actual suicide deaths, using our own data from our own system, actually occur in that risk threshold. And we find something very disconcerting, and that is that at the highest risk thresholds, very few of our actual deaths are happening at those risk thresholds. Now, you may still be much more likely to have a suicide death if you're at that risk threshold. But because there's so little people in that threshold and so many more people in the other thresholds, most of the suicide deaths are happening at lower risk thresholds. What does this mean? This means your denominator is not your denominator for your entire program doesn't include most of the suicide deaths that will happen. That's bad. If you're like us and you want to move the needle on suicide deaths. Next slide. Oh, and before we go to the next slide, I do want to give some kudos to my colleagues, Dr. Derek Smolinski, who did most of this analytic work, as well as Dr. Maria Kelber, who led most of this project work. Next slide, please. So the natural question is, why not lower the risk threshold, right? Well, in our population, we look to see what would happen if we lower the risk threshold. And the problem is you start to get more false positives when you lower the risk threshold. And that happens in a couple ways. The first way it happens is that at the lower risk thresholds, like if you take the top 10% of the population, you have a relative increase in false positives. So first of all, for these kind of analytic approaches, the false positives are very high. I'm sure you guys have already heard that. So like at 99.9% risk threshold, we're talking like 150 to 1,000 people per true suicide death that would happen that are identified that would not actually be a suicide death. Now, at that level, maybe not as much of a concern, because you can intervene on a lot of people, right, for some of those few, but we already just talked about the problem. Most of the suicide deaths aren't happening at that level. If you lower the risk threshold, not only is there a relative increase in false positives, so at the 90th percentile, we're looking at like 1,500 to 2,400, right? I don't know if you can see it there, but that's what it says. But also you have the fact that because you've included so many more people, now the absolute number of people that are false positives skyrockets. And so for us, this is the kind of issue that's super important for us when we look at population impact. We talk about an untenable situation with tens of thousands of people receiving a prevention intervention that actually don't need it. So this is the primary problem we have. Next slide. But we still go on and we say, okay, well, what happens if we actually implemented this based on our estimates of treatment efficacy? How many suicides can we prevent at these various risk thresholds using these types of approaches in our population? And unfortunately, the most likely outcome is around 0. On this figure here, you can see the number of deaths prevented. As you can see, it hovers around 0, which isn't great because that means there's not a really strong positive effect of preventing more deaths. We didn't even include 99.9 because the line doesn't even separate from 0 in a meaningful way that you could see it. But I can make this very simple. The bottom line is applying this simulation on our population with the kinds of estimates that are being published in the literature, we see less than a percentage change in total suicide deaths prevented. So that is very discouraging, but it's important for us to do this work and see what happens when we apply this to our population. Next slide, please. We also took it a step further and we said, how good would the treatment interventions have to be before we started seeing an intervention change that we would be more excited about? And so we could say, hey, what if the interventions were 40% effective? And if you don't already know this, a lot of good evidence-based interventions It's not like, they have 50, 75, 100% efficacy, right? A lot of people don't get better who get the intervention, unfortunately. Even if they would have to be 40%, they would have to prevent 40% of the suicide deaths in order to have a 1% reduction in our entire population. So we don't have interventions like that. That's kind of discouraging. 1% is not a big number. Then we say, well, what if they were 100% effective? Well, then at these levels of risk, we would only prevent 2.4% of deaths. So we kind of have this tough trade-off where you're actually providing the intervention to so many people, again, with all these false positives, or you're ending up with a change that's basically negligible. You're preventing pretty much no deaths. And so that's a serious problem for these types of interventions. Next slide, please. Now, again, I want to point out, none of this is unique to these particular approaches, right? These are problems that are inherent to identifying low-risk phenomenon in a population. But we still have to talk about them. We still have to look at it, because at the end of the day, our policy and program folks, and I think for folks out there thinking about implementing similar types of approaches in other contexts, need to consider the practical utility of these things in those contexts, given how little we can know about changes in low base rate. Also, I really want to emphasize these other issues surrounding things like, if you choose a high risk threshold, you're actually, at least in our population, and I suspect this translates to other populations, you're missing a lot of the suicide deaths that happen with that approach, which severely reduces your population impact. Next slide, please. Okay, so I mentioned I would kind of end this discussion with a very brief discussion of some of our programs and how they have started to have a larger footprint in social media, and how that has affected us and our thinking and our decisions on how we engage service members. I guess I'd start off by saying that probably most people that are watching this seminar could give us a lot of advice on how to do these things, right? We're still learning. We're not accustomed to having programs that are in social media and having people engage us about high risk health, right? But that's what's happening, and that's what I'm going to talk about. So there are programs in the DoD, if you don't already know this, that the intention of the program is to transition people to the care they need, right? Or to reduce the barriers that they may see in the care. So some people call that stigma, right? We want to reduce stigma. We want to make it easier for people to get into care. We want to give them education and information so they know this is all surrounding mental health care and psychological health. So we have programs that are highly visible, already have a footprint. And for us, and from my personal point of view, a lot of the issues that are inherent to these kinds of contexts are exacerbated for us. Things around anonymity, privacy, right? I mean, if you're trying to reduce stigma, having a situation where folks don't feel private or they feel like they might be identified by some algorithm or something could be counterintuitive, right? So these are all the kinds of things we're trying to consider. Next slide, please. So an example of one of those programs that my center has been involved in the last 10 years is the Real Warriors campaign. This is a campaign where we use in-person and virtual outreach channels. We want to improve access to care. We want to break down those barriers, right? And really what we're doing is we're directing service members to the resources they need. I think some of what this program does has similarities to some of the things people are hoping to accomplish generally with respect to reducing suicide mortality in populations. So we're directing service members to our website, which has all kinds of information. We're directing them to our resource center, the live chat of our resource center, and then we're directing them to crisis numbers. And this program has grown over the last 10 years. And if you run a social media company, our numbers don't look great, but I think for us, they look very good. Our subpopulation of service members who are concerned about care, there may be barriers to care. We think we've reached a lot of those. Next slide, please. And this just kind of summarizes our footprint across different social media. It also summarizes the types of materials that we get to people using the web and social media. But I would direct your attention to the last bullet item there, the help seeking actions per day. That really is where I think the high risk meets us here. Next slide, please. And what we noticed is that we were having people reach out to us, and we wanted to make it as easy as possible for them to reach out to us, right? So we did a redesign in 2019. We improved our device compatibility, improved accessibility, things like making it easier for people to get to those resources. We think that's super important. I guess in the context of the overall seminar that's happening right now, I'd say our approach has been different than some of the approaches we've been talking about, in that we're trying to make it easier for people to come to us. Again, because we see inherent problems with reaching out to people via these kinds of via social media and the web, right, with privacy and stigma, et cetera. We're trying to make it as easy as possible for people to reach out to us. And then we're using the same, evidence-based referral resources that we already have in our system. We get them to those same things. We're not changing any of that right now. Maybe we'll see some research, or maybe we'll see something, maybe something will come out of meetings like this where we decide to change something like that. But right now, we're not changing any of that. We're still getting them to the best practices, crisis resources they need, just as if they had walked into my center and said, hey, I have this, and this going on, right? It's just that we identified them through these other places. Next slide, please. So that's it for me. I think there's going to be a broader question and answer later that I'll be available for, but if you have a direct question for me, you can reach me at the email below. Thank you very much.